going back to our goals of decompression and stabilization, this person definitely needs decompress. They've got a bone in the canal here. So you need to remove that to remove the ongoing compression of the thoracic cord. But this is also an extremely unstable spinal fracture called a fracture dislocation. And unfortunately, spinal fractures classification is kind of outside the scope of this talk, but it's one of my favorite things to talk about. But we obviously definitely with this thing, these two disarticulated ends of the spine need to be stabilized. And so you need a very structurally solid stabilization here to keep the ends of the spine from moving around. Here's another less dramatic example. This is a Coconus level spinal cord injury. And you can see again, the two ends of the spine are disrupted. This is again a fracture dislocation. And so we really need to realign the spine, which will remove the compression. So you need to push this part forward through various means and then stabilize through fixation. And here's another really extreme example of a fracture dislocation. You can imagine here potentially that just traction or that sort of thing is not going to work. We actually had to do some significant bone removal to achieve reduction of this unfortunate person. And so again, the goals of surgery are to decompress the spinal cord, restore normal alignment and balance, and restore stability to the spine. And that is generally going to be done through instrumentation. And in many cases, certainly the ones I just showed you, you want to abide by principles of fixation that include multiple fixation points, which are usually pedicle screws or lateral mass screws, usually longer constructs, and some other principles which are really excellently addressed by the AO. Which is another great international organization. This image is from their surgery reference, which is available online, I believe, for free to everybody. And the overall goals for timely decompression and stabilization ultimately are to allow maximum recovery, okay? Maximum neurologic recovery in terms of recovery of function, but also to encourage the next stage of recovery, which includes aggressive rehabilitation, and rehabilitation includes mobilization. And so that really requires a stabilized spine prior to starting. And once you are able to mobilize that patient, respiratory wise, everything gets better. Some of the late complications that I'm going to talk about are decreased. And so mobilization is really, really key for these patients. And for that, it really is about timely surgery. One of the main reasons we mobilize in spinal cord injury is to avoid complications like this, venous thromboembolism or VTE and pressure ulcers. VTE includes both deep venous thrombosis as well as pulmonary embolism, and it's a leading cause of morbidity and mortality following spinal cord injury. And having a trauma greatly increases the risk of DVT and PE because of immobility, as well as inducing a hypercoagulable state. The risk for VTE in patients with spinal cord injury is considered to be greatest during the first 12 weeks after injury, again, due to those factors of immobility and hypercoagulability. And that hypercoagulability will start within a couple hours after trauma and persist for at least 2 to 3 weeks. Therefore, we try to start prophylaxis for thrombosis as soon as possible after injury, ideally within 72 hours. In some patients, like those with intracranial bleeding or other active hemorrhage, you have to wait to give them medical prophylaxis, but you can use mechanical forms of prophylaxis as soon as the patient is admitted in most cases. And by that, I mean like Venadines or SCDs. It's recommended to continue VTE prophylaxis for at least 3 months from the time of spinal cord injury or for as long as the inpatient rehab period lasts. Pressure ulcers are another really dangerous condition that people with spinal cord injury are at risk for without proper complication avoidance. Effective pressure ulcer management requires consideration of a bunch of factors, and usually it's a comprehensive multidisciplinary approach. Many pressure ulcers are preventable if we use appropriate interventions such as padding, turning, and mobilization. So again, that's the importance of surgery. You also want to modify as many medical risk factors as possible, including poor nutrition, which can be common. Physical, occupational, and other rehab specialists will develop sort of individualized plans, and that generally is best done through a protocolized plan that is optimized with each particular hospital. So each hospital is going to have a different protocol for this, but the important thing is that you have a protocol. With initial mobilization of people with spinal cord injury, they will often have something called orthostatic hypotension, which is when they drop their blood pressure. With reconditioning and mobilization, the symptoms of orthostatic hypotension will usually improve, but some patients will have lifelong problems with it and need medication for it or other interventions like wrapping the legs to prevent venous pooling. Opposite to the orthostatic hypotension, some individuals with injuries above T6 can experience significant episodes of hypertension known as autonomic dysreflexia. These episodes are really unpredictable and really severe, and they can actually be life-threatening. Autonomic dysreflexia is manifested by episodic headaches, really severe increases in blood pressure, and can even result in cerebral hemorrhage from that high blood pressure. And most episodes of autonomic dysreflexia can be managed by figuring out what precipitates them. There's always going to be something that incites them to happen. That can be a full bladder, constipation, needing to change positions, or other things like that. But sometimes it can just be completely random, and the patients may even need pharmacologic interventions or hospitalization to manage those things.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.